Hi everybody, and welcome back to Ultrasound of the Month for August 2013. We have no disclosures. This is an educational case. I've changed lots of facts to protect patient confidentiality. Today you are doing anesthesia. Your patient has severe COPD and comes in for a revision of a ventral hernia with mesh placement. You decide to provide a general anesthetic with an endotracheal tube and to use total intravenous anesthesia. Intraoperative, you have trouble. There's obvious air trapping and high ventilation pressures. After extubation, predictably she sounds wheezy, there are diminished breath sounds, and you stay in the operating room administering bronchodilators, naloxone, steroids, and lots of physical stimulation to maintain ventilation. However, the patient still requires intermittent mask ventilation to maintain oxygenation and displays high work of breathing. You contemplate reintubation, but you want to make sure that there is no other easily reversible cause. Did she perhaps develop a pneumothorax from mechanical ventilation? You call for a chest x-ray, but while you wait, you perform a lung ultrasound. Let's talk about theory. Here we've placed a transducer on the chest wall, positioned sagittally so that you will see a rib above and a rib below the pleural space. Here we see the parietal pleura and the visceral pleura covering the lung, which is sliding back and forth as the patient breathes. Here's a picture of myself, ribs above and below, and in the middle we see pleura sliding. This echogenic line is the visceral pleura sliding upon the parietal pleura. If you weren't sure, you could place an M mode through this. That's a single line along which we'll measure all changes that come due to movements. Here we can see in the still that the M mode is placed to the pleura. We see that over time the pleura images as a echogenic line. Above it there are echogenic lines that are not changing, corresponding to soft tissues and intercostal muscles and so forth. Below the pleural interface we see artifacts that are projected as a result of this sliding interface. This is the so-called sandy beach sign. Sand below and waves hitting the beach. What would a pneumothorax look like? This is a patient with a pneumothorax. Here we might suspect the pleural interface, but it's not clear that we see pleural sliding. Since we're not sure, we'll place an M mode. The M mode likewise does not show the sandy beach sign. There are some movement artifacts due to the fact that the patient is breathing hard and the chest wall is moving. Now, what if there is no pneumothorax but the patient doesn't breathe? What if they're holding their breath? Will you still see lung sliding? Well, here's me holding my breath with M mode through my pleura. You can still see some sections of sandy beach. These result from so-called lung pulsations. This is my heartbeat moving the lung, and at the surface of the pleura, this movement artifact causes this disturbance, the sand artifact. So you can still detect pleural sliding even in patients who are not breathing. Back to our patient. Our patient displayed lots of work of breathing. When we performed ultrasound, we did find lung pleural sliding, indicating that this patient does not have a pneumothorax. We repeated this over several sections of the chest to make sure. However, it's most likely to see pneumothorax over the apical non-dependent chest. We placed M mode through and saw the classic sandy beach sign. However, you'll notice the artifacts that come from tissues above, superficial to the pleura, which is this echogenic line. I magnified these here to show you that they should not be mistaken for sandy beach. They result from tissues and structures moving as the patient is struggling to breathe and should not be mistaken for a positive sandy beach sign. So in the further course, the chest x-ray arrived and verified that there was no pneumothorax. We transferred to the PACU, and ultimately after a few hours of BiPAP and more bronchodilator therapy and perhaps the effect of the steroids, the patient improved and was discharged to the floor. So for lung and pleural ultrasound, look for lung sliding where the parietal and visceral pleura meet. look carefully for movement of pleural surfaces, not movement of other soft tissues that may be more superficial. Lung ultrasound is superior to chest X-ray for detection of pneumothoraces. In a recent meta-analysis in trauma patients by Wilkerson and Stone, ultrasound had a sensitivity of 89 to 98% and a specificity of 97 to 100%, compared to chest X-ray, which had a lower range of sensitivity from 28 to 75% and a specificity of 100%. Thank you very much, and see you next month.